and postnatal period. So oftentimes when we are talking about maternal mental health, we seem to lump everything together. But for it to make a bit more sense to us,
Dr. Isiasamoah, we can't see. So sorry, it seems we've lost Dr. Alberta and Isiasamoah. We are trying to reach her. Otherwise, we'll just contact the next presenter to start while we sort out Dr. Alberta's problem. Thank you. Just a few minutes, please. And also for the CPD points, kindly join by putting down your full name. Okay, putting down your full name and the MDC number as you register with us, please.
So, hello. I see a lot of us are putting it in the chat. Rather, change your name. So, Galaxy One, you should change the name from Galaxy One to their full name and add their MDC or NMC or GPC number to it. Okay, that will make it easier for us. So instead of putting it in the chat, just change your name from Abena or from iPhone 5 to your real, your name and your MDC number. Thank you very much.
So sorry, please, Dr. Alberta will join us shortly. She's coming back home. Thank you.
So, my apologies. Please, can you tell me where I dropped off so that I go back to? Dr. Sefa,
We're just on the third slide.
Lemon light green.
Third one.
Yes, please.
That's one.
And I like that.
Yes, please. Yes,
All
please.
right. All right. Thank you.
Oh, say that lighter.
Okay. So, yes, I think we've sufficiently defined what maternal mental health is. So we'll move on to overview of pregnancy-related mental disorders. When the first presenter was speaking, Dr. Kumia, I believe, if you look at the risk factors that he spoke about, it's quite obvious that these risk factors did not start during the pregnancy. And so many women who get pregnant would already enter the pregnancy with existing risk factors. So I decided to break it into 3 parts: before the woman gets pregnant, whilst she's pregnant, and after she delivers her baby. What are the common mental illnesses that she may, suffer from? So for the prenatal mental health disorders, there are basically 2 categories of people. There are people who do not have an existing mental illness, but have a number of risk factors which will predispose them or may predispose them to a mental illness during the pregnancy or after delivery. And then women who already have an existing mental health disorder and get pregnant, with the existing disorder. Oftentimes, because pregnancy is an event in the lifetime of a woman, it offers us a very good opportunity to prevent a lot of the things that can occur in pregnancy. And that is the whole point of looking at risk factors. At the first antenatal visits, if we are able to do a proper screening, if we are able to ask proper questions, then it means that we'll be able to follow better women who are at an increased risk to develop a mental health disorder during pregnancy and postpartum. I mean, using my own pregnancy journey as an example, in all my deliveries, my obstetrician never asked me if I've had any mental health disorder before. And when they were talking about routine medications, that's maternal mental health is going on back here. My apologies. And when they were asking me about routine medications that I may be on, nobody inquired about antipsychotics or antidepressants or anxiolytics or anything like that. So it's quite clear that it is not part of the things that obstetricians would ask routinely. If we are able to categorize women well, then we are able to prevent some of these occurrences from happening. Intrapartum, in the course of the pregnancy, a lot of research has shown that in the first trimester, a lot of women will come up, will complain of anxiety symptoms. They will complain of sometimes depressive symptoms, depending again on how the pregnancy is, what their symptoms are, the nausea, the vomiting, which may make the journey unpleasant for women who may have suffered repeated miscarriages or abortion, women who may even have conflicts, cultural or religious conflicts, associated with a pregnancy, perhaps a single mother and married and things like that. So in the first trimester, there's a lot of anxiety and depressive symptoms that may occur, not necessarily clinical anxiety or clinical depression, but there's an upward, surge of people with anxiety symptoms, which often is attributed to adjustments in the first trimester. The third trimester also comes with a lot of fears of the impending labor, delivery, psychosocial fears such as financial implications. All these, Dr. Kumi has said them, so I wouldn't want to belabor the point, but bringing in a child changes a lot of dynamics. And so in the third trimester, a lot of women will have a lot of fears, which is also may be expressed as anxiety symptoms or depressive symptoms. As I said, several researchers have also said that there's an increased risk of depression when the woman, I've already said this, has a history of abortion, intrauterine loss, unwanted pregnancy. All that can affect. In fact, this risk, when it comes to low-income countries like Ghana, is known to be about 15 or 16%. Some researchers have stated that. Another thing that can occur intrapartum is pseudocyesis. Pseudocyesis, as the name suggests, is false pregnancy. So this is where a woman who is not pregnant, as demonstrated by a scan, has very obvious pregnancy symptoms. And they said that sometimes you can even test positive when you do a urine pregnancy test. So they may have the nausea, the vomiting, they may even have bloating, their stomach will bloat, and they may even have in fact all the symptoms of pregnancy that you can think about. But then when you go and do a scan, there's no evidence of a pregnancy in utero. And that is also a psychiatric disorder that can occur during pregnancy. I think in my whole practice, the only pseudocyesis I have seen was seen by a colleague, and the woman had a talking about, you think that she's a pregnant woman. So those are some of the things that we can look out for intrapartum. Interestingly, it is realized that the second trimester seems very stable in terms of mental health disorders that can occur. Oftentimes, it's the first trimester and the third trimester. The second trimester is usually quiet, for lack of a better word. The other group of people with mental illness that we'll look at during pregnancy are women who already have an existing mental health disorder and are pregnant. And a lot of research has been done amongst this group. Although generally, when you compare women with a mental health disorder to the general population, incidence of pregnancies are lower in women with mental health disorder, but they still do get pregnant. And every once in a while, I'm sure the obstetricians see them. We often see them, they come up. And when they mention their diagnosis, they are very important things that we should be looking at moving forward, not just the fact that, oh, this person has a mental disorder and is pregnant. There are implications for the pregnancy, there are implications for the mother, there are implications for the baby when she gives birth, and those are the things that we should be looking at. So for schizophrenia, around 20% will relapse. Bipolar has a higher relapse rate of about 2/3 of women. For depression, research has shown that people who would have relapse are people with major depression. Oftentimes, those who had major depression and then recurrent depression. If you had a mild depression to moderate depression before pregnancy, your risk is not significantly increased compared to the general population. For anxiety and panic disorders, generally, the numbers are conflicting. The research is not so conclusive. Some say that although there are high levels of anxiety disorders during pregnancy, it is not really different from the general population. And others also say that panic disorder worsens during pregnancy, which I mean is understandable. PTSD has possible increased risk for complications because of generally their what they may be feeling, the flashbacks, the heightened sense and all that may lead them to cause harm. OCD, some research said that there's 30% worsening of symptoms during pregnancy. Again, pregnancy by itself makes you conscious about neatness, about germs, about harm to the baby. And so for somebody who already has an obsessive compulsive disorder, that may lead to worsening of their symptoms. Interestingly, also, some research has shown that OCD can occur as a first time in women who did not have a pre-existing disorder of OCD, and it will usually occur between 5 weeks to 28 weeks, but by third trimester it would have abated. And another interesting fact about women with OCD is that when you compare them to the general population, they have a significantly reduced rate of unpleasant fetal outcomes and fetal deaths. So when you compare them to the population, their children do better. They have better outcomes. Eating disorders may improve during pregnancy, but they will have increased risk of postnatal depression and complications to the baby as well. How do I hide this thing? Again, intellectual disability. These are all things that come up to us in the clinic all the time. We have women who have intellectual disability. We find them pregnant. By the time that they come to the hospital, they are somewhere in the second trimester. Communicating with them is difficult. They do not seem to understand what is happening to their body, and you cannot seem to explain what is happening to them and the interventions that you make. These are all difficult situations that we encounter, or the obstetrician will encounter in the clinic. For intellectual disability, they, as you can imagine, have a lot of social difficulties. They cannot recognize who the partner is. Some are even found on the streets and brought to the labor ward to deliver. We've had quite a number of referrals, and they write query schizophrenia. You go there, you ask, and they say that, oh, the person was found and somebody brought the person. They don't know the person. And when you look at the person and you try to communicate, you realize that this is intellectual disability. For personality disorders, you have to look at, in terms of pregnancy and childbirth, it's case by case. The individual and their unique set of problems will determine what the outcome will be. Then we move on now. The woman, we have managed to carry her through the pregnancy successfully, and she has delivered. When you deliver, what are some of the problems? I mean, some advocates say that the postpartum period should be called, sorry for the background music. Some advocates, I'm in a meeting, okay? Some advocates have said that, they refer to the postpartum period as the fourth trimester, and understandably so, because the fourth trimester, as we saw from Dr. Kumi's presentation, when I was listening to Dr. Kumi, I ended up modifying a lot of my slides so that this CPD doesn't end up being repetitive, but an evidence from his presentation shows that there are a lot of hormonal changes, there are lots of significant physiological changes, anatomical changes, as well as social changes, psychosocial even changes that occur during the postpartum period. And that has a lot of implications, significant implications on the mother's mental health. So in the postpartum period, some identifiable disorders, the baby blues, well, usually you often hear the midwives saying that, oh, this is baby blues, this is baby blues. Sometimes we may end up lumping more serious disorders as baby blues, but baby blues is as soon as the mother delivers, within 2 to 3 days, it's not supposed to last for long. She becomes more tearful, may have some anxiety because of the new changes in her life. But the key thing is that baby blues will resolve within 2 to 3 days, and it's not supposed to last. Usually with a bit of counseling, which the midwives, I must say, do very well at. Some psychosocial support, the woman, will come out of the baby blues and go on to have a successful postpartum period. The other thing is postpartum anxiety disorder, which is also quite significant. Unfortunately, like all anxiety disorders, they don't often come to us, the psychiatrist. But in the general social setting, if you do a cursory research on social media pages for mothers, you realize that there's a significant occurrence of postpartum anxiety disorder. There's a lot of fear, sometimes irrational, a lot of worry. Some mothers keep awake throughout the nights. They will check their baby to see if the baby is breathing 100 times a day. They will not allow anybody to touch the baby. They have to do everything for the baby. They are so fearful that something will happen to the baby or something will happen to them. So this is quite a common thing. Oftentimes, again, as I said, a lot of times they may not report to the obstetrician or midwives, then they may not report to the psychiatrist as well, because a lot of people see these anxiety symptoms as normal. So family may counsel them, say, oh, it's part of motherhood and things like that, and they may resolve. But if it's significant enough such that it impairs function, then we may see them. Another big one is postnatal depression, which is the most common postpartum mental disorder. Dr. Kumi has spoken extensively about postnatal depression, so I wouldn't go too much into it, but that is the most common. Moving on to postpartum psychosis, which the obstetricians like the term puerperal psychosis a lot. That is another is a very severe, although not as common, is a very severe mental health disorder, and it is acute. It revolves rapidly. It has all these symptoms that keeps on changing per the hour. The woman looks perplexed. She looks bewildered. She seems confused. She seems disoriented, and she may have some psychotic symptoms as well as mood symptoms as well. And this is often a psychiatric emergency. Again, postnatal depression can also, I think what I didn't see in Dr. Kumi's presentation, it can become so severe that the woman becomes stuporous and she may not eat. She may not be able to even get up from her bed. And that has implications not only for the mother, but for the baby as well. And so intervention is needed and is immediate. Then there are these other conditions that may be subclinical. It may not fit any of the other big ones like postnatal depression, postpartum psychosis, anxiety disorder, and all that. We may not necessarily have a name for it. The mother herself may not even know what is happening to her. An example is postpartum rage, where the mother becomes so irritable oftentimes may be associated with a mood disorder, with anxiety, with depression, or even postpartum psychosis. But there are lots of times that new mothers have a lot of rage, they have a lot of irritability, and they get angry at the slightest thing and snap. I mean, they'll snap at you at the slightest incident. I remember when I had my first child, she was a very, and she still is anyway, a very light sleeper. And so you can imagine that I wasn't getting any sleep at all. I used to get so angry at even birds just tweeting and chirping away because they'll wake my child, and that will be the end of my sleeping time. So postpartum rage is a real thing, but mothers may not present, they may not even know what is happening. They may not even understand what is happening. They may not present to the psychiatric hospital. And if they do, sometimes, as my residents will say, Dr. Ma, for this one, what diagnosis is it? I don't know what to put there. So these are some of the things that we can look out for. Parental overstimulation is also another thing. It may not, a lot of times, it may, when it becomes so severe, it may result in either an anxiety or a depressive, episode. But other times, a lot of times, it's subclinical, especially for mothers who may have older children, especially toddlers. Toddlers are constantly touching you, constantly making noise, following you everywhere. So all your senses are bombarded all the time, and there's no free time. And of course, whilst they are doing these things, they are lecturing about putting toys here, doing that. And so the mother basically is overstimulated, a lot of noise, seeing a lot of things, being touched constantly, because these children are even closer to her than her own shadow. And there's no moment of, rest or alone time. They wake up with you, they sleep with you 24/7. So the woman, at the end of the day, becomes so overstimulated, and of course, it may also lead to postpartum rage. But I remember there was I read a publication about a woman who wanted, and this has come up a few times, who wanted to run away. Actually, she just wanted to abandon her children and run away because it was a bit too much for her. Unfortunately, in a cultural context, and maybe to some extent religious context, if you get something that somebody, others, not somebody, is believed to be a blessing and a gift, you can't complain. If you complain, you are seen as ungrateful. So mothers are not able to express themselves appropriately, because if you go and say something, the first comment that somebody will make is that, the thing that people are looking for, and you've gotten, and you are complaining, and words like that. Again, parental burnout is also a real thing. It's not only workplace burnout that occurs. Parental burnout is a real thing. Parents who are mothers, working mothers, taking care of 2-3 children, sometimes all by themselves, commuting to work, financial implications, a whole lot of, there's just a lot of work from parenting. So this is like parental work overload, and that can lead to parental burnout. So all these people may come to you, and the things that they will talk about may not necessarily fit depression or anxiety or psychosis, but these are all important things that you should look out for, because if you are able to help parents when they are in that stage, then we may be able to reduce the incidence of the big guns occurring, or even if they occur, we'll be able to reduce the severity of it. So what are the common signs and symptoms of these disorders? I think here too, Dr. Kumi mentioned quite a lot. These are by no means exhaustive of the symptoms that will occur or can occur in women who may present to you with these conditions. So they may have lability of symptoms, which means their symptoms will change rapidly. They may be perplexed, bewildered, express disorientation, thoughts of suicide, thoughts of infanticide, tearfulness, excessive worry. They all be part of presentation. The important thing that we should note that when it comes to maternal mental health, suicide is the leading cause of death within that cohort. So each time you see a woman or a mother be minded to ask about suicide and of course about infanticide as well. The thing about maternal mental health is that what makes it so important is that it's not just the mother who is involved, but the life of a child is also involved. And we do not want to have unfavorable outcomes. I think a few years back, there was a publication, I think it occurred somewhere in the central region, where a mother went into the sea with her baby at her back, and then they both drowned. These are all, I mean, from my professional point of view, quite clear to me that probably a woman suffering from postpartum or postnatal depression, as her case was, and committed both suicide and infanticide. So yes, insomnia, which is a real thing, postpartum. Generally, if you speak to any new mother, sleep is often one of the, in fact, number one concern. The mother, we all assume that having a baby is a blessing, is a gift, is a good gift. But if you see a mother who seems to lack any interest in the baby, she doesn't want to carry the baby, she doesn't want to feed the baby, she doesn't want to play with, she doesn't want to do anything with the baby, that should prompt you to delve sadness, irritability. Somebody may express excessive energy, agitation, even aggression. As I said, the symptoms and signs are a lot. What are the risk factors? We've seen the symptoms, we've seen the signs. What are the risk factors? Since we want to look at preventative medicine, wants to practice preventative medicine more than curative. So if we know the risk factors, then we can prevent it from occurring, reduce the incidence, and that has a lot of implications. It means that our hospitals are not going to be overburdened, our health workers are not going to be overburdened, the workforce will not be overburdened. We end up invariably saving everybody a lot of time and energy. And of course, the implication for the mother and the child, whenever there's this event, the bonding process between the mother and child is impaired, which also may have long-lasting effects on the child well into adulthood. I think the psychologists may talk more about that. So this makes maternal mental health, or the perinatal period, very, very important. Risk factors, again, a lot has been mentioned. I think that I'll look at a few ones. I'll just hammer on a few things. The outline says that the focus of this CPD should be on psychosocial and environmental factors, and rightly so, because those are the ones that we can do something about. Your biological or genetic factors, we can't do that. We can't go and wash out your genes. We can't change your family history, but the psychosocial and environmental factors are things that we can do something about. So women, again, the first antenatal visit is very, very important. It's crucial. A lot of our screening, that is where we should. Yes, currently the focus is more on physical conditions, medical problems, but it's also a fine opportunity for us to fish out those who may have psychiatric problems or be at risk of getting psychiatric problems. So these are very easy questions that we can ask. Unplanned pregnancy, ambivalence about the baby, whether the person has marital, family, or social support. I think that the midwives ask it, but they don't follow it up because they will ask you whether you are single or married and things like that. These have real implications against maternal health, it's mental health, and those are the areas that we should look at. We shouldn't just leave it at whether single or married. I remember again when I was preparing the slides, I did a case research. I did a case research on Facebook on a mother's page. It's called Tell It Moms. It has a lot of, if you're interested in all these social things, so I'll say a little social experiments. And with this marital and single issues, I mean, a lot of people are offended when midwives ask them, especially, of course, if you are married, there's nothing to be offended about. Oftentimes, single mothers who are pregnant are often offended when midwives ask them if they are married or single. And some may even buy rings to wear during the pregnancy period just so that they will appear as pregnant. So all these, you can see that there's a lot of psychosocial. Hold on. Hello, Susan. Hello. Am I audible, please?
Yes, you are.
Yes.
Greta is calling me. Kindly hold on. Hello, Susan. Hello. Yeah. So if midwives are able to explain the reasons for this, I think that the mothers will better understand it. It will help them open up and share their problems and help us to screen people out better. All these have been mentioned by Dr. Kumi, so I'll skip. What I really want to hammer on here is rapid discontinuation of medication during pregnancy. By medication here, we are talking about psychiatric medication for women who were on it before they got pregnant, or for some reason were put on it during pregnancy. Oftentimes, the women may stop themselves, family may advise them to stop, and sometimes some health workers may say unguarded things in front of the patient, and that may lead the patient to stop the medication, and that's is a risk factor. So what are the referral paths? Oftentimes, these women will be at home after delivery. If everything went well, they will be at home. So if you are there with their partners, their mothers, their social support systems, if they have, should reference the risk factors, the signs and symptoms that we've already discussed. When they see any of these, they should persuade the person to share with their midwife or obstetrician gynecologist when they go for their routine postnatal care visits. Again, the other group of people I wanted to mention here are also pediatricians, because during this period, the baby is also cared for by pediatricians. So if they are uncomfortable with their obstetrician gynecologist, they can open up to their pediatrician, their child's pediatrician, who may be a bit more friendly. There are a number of tools that are the obstetrician's office whilst they are waiting, when the midwives are doing their education. They can add mental health education so that if somebody has it, they can open up. And there are tools for people who can read and write. These are very simple tools that they can answer, especially in private practice. They can answer, and when it's their turn to see the obstetrician, they can share. You can also, oftentimes when people are facing such problems, they may not come to the hospital first. They may see their pastor, they may see a counselor, or somebody may recommend that they see a psychologist, which is generally people think is more benign than psychiatric care. So that is also a start point. You see a psychologist. If you're a psychologist or a counselor, and you see the person, then you refer appropriately. Of course, the last one, the major one, is the psychiatric care. So the management really can be divided into two, pharmacological and non-pharmacological. I will not bore you with the pharmacological treatments. We can look at the non-pharmacological treatments. As we realize, there are a lot of psychosocial and environmental risk factors. So as part of non-pharmacological management, social interventions are very important. Get social welfare involved. If there are any other any other agencies that can help, you can make useful suggestions so that the social problems that the mother may have shared with you can be lessened or can be solved. A simple thing like asking her to get help. It's okay to get help. It doesn't make you less of a mother, and things like that can go a long way to help mothers. Psychological management is part of non-pharmacological management. Child protective services, very important. In some situations, the child may be in danger, and you may want to inform social welfare again, or child protective services if you have that in your jurisdiction. The last non-pharmacological management I want us to look at, which is very interesting, is baby and mother units or postpartum care centers. In the past, when you deliver, you are supported by family, but with increasing urbanization, that's family support may not be too strong or may not be there at all. And that is a fine opportunity for people who may be listening in. It's a fine business opportunity to set up postpartum care centers where mothers who do not have family support can go, so that when they are discharged from the hospital, they don't go home, but they go to these care centers and they are taken care of appropriately, given the necessary advice, taught how to breastfeed, because nobody is born knowing how to breastfeed. You have to be taught all these things, because when these things do not go well, it has negative implications on the mother and predisposes her to adverse events. For medication, the interesting thing I want to talk about are two things: prophylaxis and electroconvulsive therapy. A lot of research has looked at prophylaxis. The research mainly is for lithium and olanzapine, and they realized that for women who have a high risk of developing a postpartum event, even if they had a very safe pregnancy, there was no event during pregnancy, it is prudent, or it may be prudent, to start a prophylactic treatment as soon as they deliver. You do not wait for them to go into a postpartum psychotic episode before you start your medication. So there are a few studies to support that for such women, when they were, in fact, they did it in two groups. They did those who refused the prophylactic treatment and those who took the prophylactic treatment, and they realized that the event of postpartum psychosis in those who took the prophylactic treatment was far lower than those who didn't take it. And of course, electroconvulsive therapy, which has been shown to be safe in pregnancy. It has, here you are not going to use medications, and so concerns about breastfeeding may be reduced as well. The other thing that you have to also look at is that when you are discharging a mother who has a postpartum psychosis, one of the advice, we have to be careful the kind of advice that we give, because research has shown that when you have a postpartum psychosis, yes, your risk for other postpartum events is increased, but also your risk for non-postpartum psychiatric disorders are also increased. So you may be cautious if you want to give an advice that if the mother asks you, so if I don't get pregnant, will I get postpartum psychosis again? The answer is not yes, because research has shown that women who have postpartum psychosis are at risk of getting psychiatric disorder unrelated to pregnancy. So the moderator has called me several times. I'll end here. what I want to say is that maternal mental health is also part of total health, as MHA's, I think that is their motto, if I'm not mistaken. It's part of total health. And so let's make it a reality. There's a lot that has to be done in this group. Thank you. These are my references. I have a lot of references. If you have time, you can take a look at it. Thank you.
Thank you, Dr. Alberta Isiasamu. I think you ended rightly. As we stated, the program is MDC accredited. So make sure that you have your name there fully written down as registered with your professional body with your PIN, your MDC PIN. Okay, don't put it in the chat box. Join using the name as registered with your professional body. Thank you. You've also realized that over 500 people are on this program, and so we had to share another link for you to join on YouTube. That is in the chat box. So yes, I think we'll quickly move on to the third presenter. Thank you, Dr. Alberta Isiasamu. It looks like for pregnancy and postnatal, we mothers suffer a wide range of mental health conditions. And today I'm learning about postpartum rage, parental overstimulation, and parental burnouts. And there are many things that we need to talk about when it comes to maternal mental health. Yes, indeed, maternal mental health or mental health is total health. I would quickly introduce our third presenter, Dr. Jifa Abra-Atta. So Dr. Atta is currently a lecturer at the Department of Psychiatry, University of Ghana Medical School, Legon. She also runs, and she has over 13 years of clinical experience providing mental health care to women, children, and adolescents. She's experienced in assessing, diagnosing, and treating trauma and stressor-related disorders, helping her clients live meaningful and fulfilling lives. Her current research work focuses on the development of psychosocial interventions to promote mental health and treat mental health disorders. She has co-authored a number of peer-reviewed articles and book chapters on various aspects of mental health, including topics on sexuality, abuse, study abroad and re-entry experiences, task shifting, and digital interventions for mental health. Dr. Jifa Atta would assist us go over the resilience, and how to build it generally and particularly in mothers, and the practical approaches for incorporating resilience. Should go over coping strategies and protective factors, and the non-pharmacological management of mothers who develop mental illness during pregnancy and after delivery. Dr. Jifa Atta, you can kindly comment. Thank you.
Thank you very much, Dr. Sepa. Is it possible to enable the sharing screen? I'm getting a message that you cannot share your screen. I think Alberta hasn't stopped sharing.
Okay.
Okay, so please confirm that you can see my screen.
Yes, please.
Yes, we can.
Yes, please, we can see.
Okay, great. So good afternoon to everybody. I know it's a holiday. We should be relaxing and chilling by now, but this is also an important topic, and I hope I can make it interesting for you. So without wasting too much time, my emphasis is going to be on resilience. So we've spoken a lot about the risk factors. It really makes pregnancy and the aftermath look very challenging and difficult. And honestly, that is the truth. That is the experience of many women. They go through a very difficult and challenging time. although in society, everybody is expected to be excited because there's new life in the family. So culturally, and I think Alberta mentioned this, you are not able to express how you're truly feeling. So even if you are having concerns, you are anxious about something, you're not able to express it freely because of our cultural context. So you may see a pregnant woman, and well, as soon as you know somebody is pregnant, especially for the first time, it can be very exciting depending upon the circumstances. But the individual is going through a lot. And I would like to emphasize here, because many times the men say we leave them out. So I'd like to emphasize that although a lot of the burden is on the women, men also go through some challenges during this time. So it's more than meets the eye. So you may just see the person physically and think, oh, okay, the person is pregnant, right? The person may be dealing with very difficult circumstances. That doesn't downplay the fact that they may be excited that they are having a baby. But as my former presenters have said, sometimes pregnancy happens in very difficult circumstances. So it's important that we talk about resilience. So I'm going to touch on resilience, and I'm hoping that by the time we are done, you have a clear understanding of what resilience is, how this can apply to maternal mental health, and also understand the protective factors, or some people call them assets, and various coping strategies that women employ. But then more importantly, as health professionals, also understand what your role is in being able to help mothers build some level of resilience. So my outline is pretty simple. I will be touching on resilience, maternal resilience, and then protective factors and coping strategies, and then the role of the health professional. So I want you to kind of think back to when we were experiencing COVID. So COVID was a very difficult time for majority of people, right? And in 2019, we were all celebrating Christmas. We saw on the news, I think somebody has the microphone on. We saw what was going on in the news. We were still celebrating, feeling sorry for those in China. Little did we know that somewhere in March, we're also going to be affected by COVID. And it was a very difficult period for most of us. And some of the ways that people were dealing with it were pata by June, all of us would have been gone. People were using humor to deal with thoughts of anxiety. Could I have COVID? Would it affect me? Would I be able to survive it? It was a difficult time. But interestingly, as human beings, we have the ability to adapt to very difficult and challenging experiences. And you don't only need to think about COVID, but remember when you went to school for the first time. It could have been primary school, it could have been senior high school. At that time, it may have seemed that because of the transition and change, you wouldn't be able to deal with it. But somehow, you were able to adapt, even though it must have been challenging. And when we are adapting or adjusting to any kind of change, we do this through our thoughts, we express it through our emotions, and we express it through our behavior. So if you go back to thinking about COVID, we were anxious because we were thinking, it's possible that I could have contracted COVID, or even if you are standing by somebody and the person coughs, does this person have COVID? Would I be affected? Those could be negative thoughts running through your mind. And as a result of being worried that you may contract COVID, you may also start feeling anxious. So that's an emotion, and you're expressing concern because there is fear that you may have contracted COVID. Because of COVID, we had to find innovative ways of doing things, and we are still even using some of these things. So platforms like this where we can have meetings. So because of these difficult circumstances, we had to come up with innovative ways, and this involved a lot of flexibility. Flexibility in the way we thought about the pandemic, the flexibility about the way we expressed our emotions and coped with the situation. And you realize that during that time, if you were not somebody who was conscious about hygiene, that was one of the times where you would consider using a sanitizer, washing your hands, using a mask. There had to be some behavioral flexibility there because of changes that were going in the country. So we had the Ministry of Health instituting certain guidelines for everybody. So there were external demands and also internal demands from you as well. So that is a good example of a situation that you need to we had to adapt to, right? Because there was a difficult circumstance. COVID is over now, but we're all able to go through it. Now, I want you to think about somebody being pregnant, at least starting from the point of it being announced that you are pregnant. Depending upon the circumstances, were you expecting a child? Did this come as good news or bad news? Are you a single mother? Did you just lose your job? So think of all the risk factors. And Dr. Kumi also talked about other difficulties that young mothers may face because of their biology. So when you talk about maternal resilience, if you want to apply that term to this particular period of transition, then you're talking about the ability of a mother to endure the unpredictable challenges that come with the journey of parenting. So there's a lot of uncertainty when you get to know you're pregnant. Sometimes these days, people don't even want to know what the sex is. They want this whole sex reveal. And there's a lot of uncertainty, and it comes with you learning how to adjust to your new role as a parent. And the ability to do this, the ability to adapt, the ability to adjust, is what we term as resilience. So look at it in this sense, a mother's ability to accept fluctuations, because you will not always be the perfect mother, okay? So there are going to be times where you're going to be expressing some negative emotions because of the role that you are playing. So your ability to just accept those fluctuations in parenting, satisfaction, negative emotions, experiences with this parenting role, and the imperfections, like I mentioned, you are not perfect. And at the same time, being able to connect emotionally with your baby when it comes. So there's kind of a lot going on there. So we've heard a lot about risk factors. So I want you to think of maternal resilience in this particular sense. So some individuals are at more risk than others. So Alberta touched on the fact that some individuals may be at risk because they have an existing mental health condition, and then also other social factors like being a single mother, pregnancy unplanned, in addition to being pregnant. Now, depending upon how an individual adapts to this situation, it will have an impact on the person's maternal outcomes, which could be positive or negative, depending upon your adaptive capacity. So when we talk about adaptive capacity, we are talking about somebody's ability to adapt, minimize, prevent, or be able to address the difficulties that you may experience because of the pregnancy, and then also because of the risk factors. So the focus is on the adaptive capacity of the mother. And this is where we come in, because we should be able to help a mother develop their adaptive capacity. So think about it in this particular sense. Any kind of care that we are offering to our client, right, should be able to decrease the impact of risk factors or improve the mother's ability to adapt to the transition, right? Or it should be able to support the kind of intervention that you are implementing, okay, in order to have positive maternal outcomes. So at the end of the day, the focus is on being able to uncover a mother's protective assets. So every mother, even though we talk about we've laid kind of a lot of emphasis on the negative aspect of being pregnant or having a baby, right? We want to be able to uncover the strengths and the protective factors of mothers. And this is what is going to enable us have positive maternal outcomes. So anytime you are thinking of how can you help a mother in that particular regard, your aim should be at reducing risk factors or improving their adaptive capacity, right? And once the adaptive capacity is improved, it also helps support certain interventions, right? And that leads to positive maternal income. So I want you to think of a mother who has been told that they are pregnant, or a mother who is just about to go into labor, or a mother who has just delivered. In any of these stages, you've got to be able to think about what are her protective assets, what are her strengths. And these are actually things that even if they do not exist, they can be cultivated. So these are things that one can actually learn, okay, and employ in any of these circumstances. And when we talk about adaptive capacity, it could be internal. So what kind of personal attributes does this mother have that could help her cope with this particular period? What external resources does this mother have in terms of social support or the broader factors? So within the community, what kind of resources are there? Within the person's culture, right? Within the very environment that this person lives in, what factors exist? What protective assets are there that could help a mother cope better during pregnancy and afterwards? So I want you to kind of think of that. So we're going to look at internal and external factors, protective factors. So for starters, let's kind of focus on the individual's personal coping skills. So everybody has personal coping skills. And even before a mother gets pregnant, the person has some personal resources. And all of these resources are helpful in being able to cope with this transition. So some of the attributes that are helpful for mothers are the attributes of being able to make sense of what is going on. So I'm going to use certain quotes. So this was work that was done. I think Dr. Kumi mentioned this earlier on, work that was done and led by Dr. Sefoga on the situational analysis of maternal mental health in Ghana. So I'm going to be using quotes of mothers that we interviewed. So we interviewed mothers that just got to know that they were pregnant and they had started their antenatal, going for their antenatal classes. Women that had just gone through delivery, women that had gone beyond 2 weeks after delivery. Now, some of the things that we found have been helpful for mothers is when they are able to make sense of what is happening. So amidst all of the difficulty, if a mother is able to kind of reflect on their experience, so whether it is going through a difficult transition period, your clothes are not fitting, you are not able to smell anything, all of that, even though they are going through some difficulties, if they are able to make sense and say that, okay, even though I'm going through this, right, I think of this also as being a blessing, because in a few months, I'm going to have a baby. So being able to make sense and relating it to some value, right? So you need to be able to, as a mother, regardless of what you're going through, you need to be able to reflect on the experience, acknowledging that there would be difficulties, but focusing on the positive side. So one of the things that a lot of mothers have talked about that have helped them is having a positive mindset, okay? So having a positive mindset means that you are projecting that, well, things may not be okay now, but eventually things would get better. And we had one pregnant woman say that for her, what has been helpful is trying to have positive energy. So just being around positive people, keeping positive thoughts going has been helpful. So no matter how down this woman is, she always tries to maintain positive vibes. So this was something that a mother identified, and this resonated with a lot of other women. So making sense of your situation and then also reframing your situations and focusing on the positive and drawing on all of the positivity that you can get. Being resilient requires some level of flexibility. So this means that you need to be open to experience. Remember, I mentioned that there's a lot of uncertainty, especially if it's your first time, but even a lot of mothers will tell you that sometimes pregnancies are never the same. So you need to be able to embrace change and learn from your experiences. One mother said, I always tell my mind that it's just a matter of months. Within 9 months, God himself will show up. So you just try your best and have positive energy. So then again, you see the flexibility in the way you are thinking and then learning from your experience and then forecasting that things will get better. So people see me and they think I'm too playful, but I tell them that no, this is not that too. So this is somebody who has to be a bit flexible. She's going through a difficult time, but as much as possible, she needs to keep the positive energy going, right? A little bit of it will require some humor. People may see it differently, but this is her way of coping. And this is one of her skills. As part of being able to build resilience, one of the things is using your various coping mechanisms. And one of it would be problem solving, taking action. So there's a problem, you've got to think on your toes, what are the possible solutions to this problem, right? And then kind of weigh the options in terms of what are the advantages if I take the solution? What are the disadvantages? So there's lots of work to be done at home. And you are solely in charge. Husband is not around. What do you do? List of things that you may list is, okay, can I get help from my sister? Sister is not available. Can I get help from, say, a cleaner to come and clean up the place? So exploring different solutions, but being focused about it and taking action is also helpful for a lot of mothers. And this is also a skill as well, which involves a lot of planning, but is helpful in terms of building some level of resilience. Some self-care strategies that mothers have employed over the time because they are able to reframe things, keep a positive mind, and being flexible with their thoughts is that they are able to seek clarification. So if you look at the literature, you realize that there's a lot of anxiety because mothers are not well informed, right? So the opportunity to seek and ask advice from trusted sources is a self-care strategy that some mothers use. And in the study that we carried out, we realized that they looked up to mother figures in terms of seeking clarification. But sometimes the question may be medical. So then it's important that they are able to speak up and speak to their health professional. Self-care strategies that people employed on because they had certain personal attributes were thinking positive. So I think that we should tune our mind and think positively. The thoughts will surely come, but when it comes, overcome and suppress it and motivate yourself, and it keeps you moving. So this is an important thing because this pregnant woman was admitting that, you know what, whether you like it or not, those uncomfortable thoughts, thoughts of guilt, thoughts of, am I doing it right? They would come. So you have to find ways of counteracting those thoughts to keep on moving. Otherwise, you may feel stuck. So thinking positive is extremely important and a self-care strategy for many women. The fact that you are pregnant or you have delivered, it doesn't mean that you shouldn't find ways of relaxing. You need to seek ways of relaxing and being intentional about it. For some women, they mentioned that listening to music is helpful. Yes, because it calms your nerves and it calms you down. One pregnant woman mentioned this. Another woman mentioned that another way that she relaxes is to go on Facebook, watch funny things, read storybooks, laugh, and then relax themselves. Other people have spoken about talking to a particular person that makes them feel calm. Everybody is different, so you would have to kind of find your own course. But all of these things help in improving your adaptive capacity and your ability to adjust in a difficult period. Other self-care strategies women have employed because of their personal attributes is keeping active. So one woman who had just delivered was talking about doing, what was helpful for her when she was pregnant was exercise. She mentioned that she thought it was helpful and it was something that she would recommend to other women. Keeping active is extremely important. And there are various ways that you can do this in terms of, let's say, you want to do something in the house. If you have the strength to, but your baby is still up and you want to put the baby to sleep, you can put the baby at your back and still walk around and do things. So the thing is, as much as possible, trying to get back into your usual routine is helpful. But another thing is you are not superwoman, so seeking help is important, both at home and then also within the hospital setting. So at home, some mothers talk about they having to seek for help, especially during the earlier days, just so that they can be able to take care of themselves and take care of their baby better. And I think this is extremely helpful because many women are not able to give their all because they haven't taken care of themselves yet. So they need that kind of support. And luckily in our culture, we have that context where usually when one is pregnant, you would have your mother come over. And these days, there's a lot of contention between the in-laws and the mothers, but usually it's the mother that comes over to kind of help and support. And we do have some supportive husbands as well that can help care for the baby as you adjust. As you adjust and you've come back from the hospital, or even afterwards, these things can be kind of negotiated. But the most important thing is to not be the superwoman but to ask for help and also delegate some of the responsibilities or negotiate. Some women have spoken about how even within the hospital, some mothers are not able to ask the doctors questions. And this particular mother was insistent that if you need something, you can tell the doctor. There are people who do not ask anything and tell themselves that they are afraid to ask the doctor. So if you need anything, simply ask the doctor or nurse, finish. And this was somebody who spoke about the fact that she had gotten a lot of support from the nurses and the doctors. Sometimes, because of bad experiences, some mothers are afraid to ask this. So this is one thing that you need to think about. Sometimes don't wait for the client to ask, but you should be asking the question of how you can support. And beyond personal attributes and self-care techniques that mothers have developed, what has been helpful is social support networks. So mothers talk about the one person that you would need to be by you to support you in a time like this is the one who made the baby with you. But this is not the case for everybody. But for a lot of mothers who do have supportive husbands, this is extremely helpful because then you can share the responsibility. So one mother spoke about, my husband is very supportive when it comes to pregnancy, and I think he has contributed to my positive vibes. He has also helped me. Sometimes when I want to do something, he will say, oh, Mama Lily, sit down, we'll do it for you. And I think in all of this, it has made my pregnancy journey smooth. I mean, who wouldn't want a partner like this? Another person mentioned, I've heard that at some hospitals, they have daddy clinics. So I would suggest we should have a daddy clinic here. They should give the men an opportunity to be involved because it's not only the issue of women. So women calling also for support from their partners. And I think also calling on hospitals to create that context where some of these things could happen naturally. For many women, as part of their social support network, and I mentioned this earlier, having a mother or a mother figure is extremely helpful, especially when you want to clarify some things. So one mother after birth mentioned, I just get the support from my mom. Normally, sometimes I ask certain things. I'll be like, so when you're going to give birth to me, how are you feeling like? Or your first child, when you were going to give birth to your first child, how are you feeling like? She'll be like, I was also nervous, but we will all try. But if you go through this first one, the rest will be okay. So normally she advises me to stop thinking and have a positive mind. So whatever happens, just appreciate. So this is somebody who has gotten support from a mother figure who has had a similar experience, so they can connect on that level. And sometimes all mothers want to hear is somebody validating their feelings or calming them down or telling them that everything is going to be all right. Some others talk about the fact that even though sometimes you would want your husband supporting, he may be the one person who is irritating you. So it's not always that you would want to have your husband by you. So sometimes you just need that friend and that confidence, right? Where you could just have them stand by you. And I think a lot of mothers emphasize a good friend, right? Not a bad friend. Somebody that you can talk to. And I think somebody who makes you feel at peace and makes you feel calm. For a lot of mothers, one thing that was helpful for them in their time of pregnancy was connecting with other mothers. In this situational analysis, there were some focus group discussions that were done. And just meeting together with other mothers. And many of these women thought that it was nice to hear other people's stories and connecting and seeing that some of your experiences are normal. And beyond your social network, there's also community support. And some research also indicates that there are certain self-help support groups. So I think Alberta mentioned the Tell It Mums. For many women, when they are asking certain questions, this is one place that a lot of women go to and they get some level of support. Sometimes people also get support from NGOs. I think Basic Needs has done a lot of work in this particular area. Then you also have churches also who support women going through that phase. One person, and this is a story of somebody who had a lived experience of postnatal depression, who said that one of my neighbors visited me often and would sit by me for hours, even when I said nothing to her. As I recovered, I found her by me, and we bonded well as the days went by. We remained the best of friends. So sometimes just your presence can be helpful for somebody's mental health. Dr. Kumi mentioned this earlier on, that what a lot of women, or the kind of role that mothers are expecting of health professionals, is for them to be able to provide quality mental health care, right? Some of the things they touched on was sometimes we wait too long when we come to the hospitals. It's very difficult sitting for long periods. So if waiting time could be improved, that would be helpful. Remember that as part of building resilience, mothers will draw resources from their external environment. So making that environment conducive for them is extremely important. So considering a shorter wait time for mothers. Another concern of them, especially for those who were struggling with mental health conditions, was the issue of privacy. People wanted their conversations not to go beyond setting perimeters, and sometimes the hospital settings are not conducive. So you have two doctors sharing one room. Whatever conversation is going on the other side can be heard on this side. So that was also a concern for them, and they thought creating an environment where privacy could be ensured was extremely important. For mothers who were on medication, one of the things that they emphasized on was improving access to medication. One of the things that I really want to highlight, because it's important if we want to support mothers being able to build some level of resilience, is promoting and strengthening compassionate care. A lot of the ways we communicate with these women can be extremely confusing, and some of the things that they noted were issues of nonverbal cues. So some of them, and I don't know why most of the time it points to nurses, but a lot of the time fingers were being pointed at nurses that they don't smile. Sometimes even nonverbal cues are helpful, right? And these are sensitive ways of communicating that you care about them. Remember that especially at the time they are in labor, they are very uncomfortable. So as much as possible, if there are certain things that you can do that would not cost a penny, that would help create a comfortable experience for the mother. Things like just smiling, to them, going by their bedside, checking on them, are helpful. Verbal communication is also extremely helpful. A lot of what mothers want to hear is that you can do this, right? Or things will get better. You're doing well. Words of encouragement and assurance is what they are usually looking out for. It's important that as health professionals, we learn how to show empathy. And one person said the way they talk, the way they attend to you, they are very loving and very caring. That alone is a plus. So these are the simple things that you can do to help mothers build some level of adaptive capacity. One of the things that a lot of hospitals are doing is the pregnancy schools. And for many mothers, this has been helpful because this is a space or a platform where they're able to get accurate information about the things that are happening to them. So they are taught things like the kind of diet, exercise, how to handle a baby, the daily activities, and all of these things are important. Some others talked about even beyond that, there's a WhatsApp platform. So if you were not even able to attend the class at that particular point, you could ask a question and get some clarification. So those made those sort of platforms were helpful for these mothers. Now, as a health professional, think about the fact that all a mother wants is a safe space. A safe space where they can vent and talk about how they have been affected because of their pregnancy and not be judged. They just want their experience to be normalized. So that all of the guilt that they may be experiencing or the shame because they are feeling tired, but they still have to, wash and care for their baby, they can deal with that adequately. All they want is also support, and it's helping if they get support from mother figures. It's important that for a lot of mothers, they do not experience isolation. So those are some of the things that you can be thinking about, and that also they have the opportunity to share some resources. Because of time, I just want to quickly talk about this. So there are certain tools that are already being used, but I came across the antenatal psychosocial risk questionnaire, and I think this is a helpful tool and would be helpful in capturing a lot of the psychosocial risks that a lot of mothers go through. And it will also be helpful in facilitating a discussion between a health professional and the mother, and then also establishing a care plan, and if necessary, a referral. So this is something that I would encourage people to look at. I think it would be extremely helpful in the care of mothers. Some of the simple things that can be done, especially at the early stages where mothers are dealing with symptoms of anxiety or depression or experiencing postpartum blues, is psychoeducation, being given accurate information about what happens when you are pregnant or being prepared for childbirth. Practical things that would be helpful for them are things that any health professional can do. And then also one role as a health professional would also be to connect with other professionals. So connecting the mother to a dietitian, encouraging a mother to do exercise during these phases, encouraging a mother to connect with other women. All of these things are helpful and provide some support and help a mother build some level of resilience. Another thing to also consider, and I think it was mentioned earlier on, is also connecting mothers to social welfare or child protective services or NGOs, depending upon their unique conditions. I just want to also emphasize on the fact that some mothers may have existing mental health conditions, and it's important that we take note and we are still monitoring them over the period. I want to, as I end my presentation, I just want to talk about a particular case. So this was a case of two sisters who were pregnant. One sister almost lost her baby due to complications at birth. With a lot of difficulty, she was able to survive it, but struggled with postnatal depression. But got a lot of support from her sister, who was also pregnant. A month later, the sister went into labor, but unfortunately died. And this took a toll on the sister, because not only was she dealing with the difficult pregnancy, also had a mental health condition, but now she had lost the sister and now also had to breastfeed the sister's baby. So even though it was, as health professionals, we need to be able to monitoring the mother over time so that we can pick up on some of these things. And truly, some of these things cannot be resolved and may need to be referred to the specialist. So when you talk about psychological therapies, you can talk about cognitive behavioral therapy or interpersonal psychotherapy. And these have to be done by trained professionals. And because you may have individuals already struggling with mental health conditions, one of the things that you may also need to consider, especially because pregnancy is a stressful period, is relapse prevention. That is also something that can be done by a professional in the field. Also, there's a lot going on during the pregnancy, and at some point, you may need to do family therapy to help support the mother through the process. But all of these may require some specialized care, so then you would need to refer to a psychologist. At birth, some mothers go through some very traumatic experiences. So it's important that for that reason, they experience or they receive post-traumatic counseling, which addresses the traumatic incident that they may have gone through, and also offers some support as they recover. Some mothers may require some directive counseling depending upon their circumstances. And this also requires a professional being supportive and listening and also doing some problem solving. Sometimes mothers struggle with their interaction with their babies because of their condition. So some therapies also look at that, provide feedback, and teach a mother how to deal with those impaired mother-infant conditions. So I would like to conclude here by saying, even though pregnancy and the aftermath can be a very difficult period, a mother can also adapt and grow through the process. And this is based on the individual's adaptive capacity, which can be fueled by the person's personal attributes, the kind of social support they get, and then the broader environment. And your role as a health professional involves creating a conducive environment for that individual to develop some level of resilience. So as this month is a purple month, I want us to kind of think beyond the purple month, and let's work together to support the mothers that we see so that they can become amazing, thoughtful, strong, happy, selfless, and resilient mothers. I'd like to end my presentation now. Thank you. And these are my references.
Thank you, Dr. Jifa. That's a very extensive approach in building resilience in our mothers, a very practical approach to doing that. We have a final presentation by Mrs. Vivian Ofori Dankwa. Mrs. Dankwa, if you are here with us, kindly share your screen as I introduce you.
Thank you so much.
Okay.
Good afternoon, everyone.
Hello, Mrs. Dankwa. Kindly.
Yes.
Yes, Mrs. Vivian Dankwa is the Deputy Director of Nursing Services at the Ghana Health Service, Family Health Division, Reproductive Health since May 2013. Prior to that, she's been a midwife and the head of the training college at Trifopra. Mrs. Vivian Dankwa is highly involved in professional organizations and workshops with a keen interest in maternal and child health. Mrs. Vivian Dankwa, kindly go ahead. Thank you.
Thank you. I'm sharing my
Okay, so whilst we wait for Madam Vivian to share her slides with us, kindly note that this is MDC accredited. You would have to put down your full name as registered with a professional body, as well as your PIN. If you have any questions, you can put it in the chat box. Right after Madam Vivian's presentation, we'll go over the questions and then give appropriate answers.
Whilst trying to share my screen, good afternoon, everyone. I am honored to be speaking with you today about a critical aspect of healthcare that is often overlooked or not adequately looked at. We have a unique opportunity today to make a positive impact on the lives of mothers and their families. Kindly let's grab this opportunity by listening attentively to this part of the presentations. Sorry, I'm still sharing.
Sorry, one thing.
Mama, kanu ne jiji ne kanu ye che yo ando kabasi na kwa votara kota kwere jiko.
Okay, so it looks like Madam Vivian is having challenges joining. Madam Vivian, are you with us? Vivian, are you with us? Okay, so what we can do now is to go with the questions. If you have any questions, you can drop it in the chat box, or you can raise your hand, we'll unmute and then ask your questions. We've had 3 presentations so far from Dr. Kumi, Dr. Alberta Nsia Samoa, and then Dr. Jifa.
Hey.
Okay. Are there any questions for now? Okay, so I think I have a question here for our presenters. Maybe Dr. Kumi and Dr. Mafo can assist with this question. Sorry, so I have a question here by one of the participants. She says, I have a pre-existing mental illness. Can I go ahead and get pregnant? And throughout the journey, how do I get the needed support? Dr. Kumi, Dr. Insia Samoa, can you help out with an answer? Thank you. Maybe we can start with Dr. Kumi first.
Okay. All right. Thank you very much, Dr. Sefa. So that's a very important question because as we've all talked about, there are a lot of things that predispose our women to maternal mental health.
Yes.
However, as has been talked about, I mean, I talked about it in the pathophysiology that it may expecting that it may not be the pregnancy itself, okay, but an interaction between genetic factors, you know, and then the social bit. A lot of patients who may develop maternal mental health disorders may have a pre-existing illness. Now, the aspect of preconception care is important because what actually in this situation may stress the patient, and the discussion has begun, is the medications I'm taking, will they have any effect on my unborn baby? Do I have to increase the doses? Will I have worsening of my symptoms? So these are important questions that will be in the mind of any woman who, just like the person who asked the question is talking about, that I have this disorder. I'm already maybe taking some medications. Is it going to get worse? Is it going to affect my baby? And this is important, and that is where there has to be a collaboration between maternal fetal medicine specialist and the psychologist or the psychiatrist, because they can look at the medications and decide to make changes or adjustments. And then, of course, early dating of pregnancy is important here. And then the rest will be done, as I said, by the maternal fetal medicine specialist. So if this patient is being seen, you know, at a primary level, this is important for the patient to be seen by a maternal fetal specialist person that will work collaboratively with the psychiatrist to help this patient answer these questions that I've talked about regarding medication, worsening of symptoms, and even its impact on the condition's impact on the unborn baby. So
Please hold on.
those are my responses to that. Thank you.
Thank you very much, Dr. Kumi. Thank you for answering this question. Madam Vivian, are you back? Are you here with us?
Yes, I'm with you.
Okay. Are you able to share your slides now?
Not yet.
Not yet. Okay.
Dr. Sepa, can I add a little to what Dr. Kumi said whilst we...
Yes, please.
Yes, if I heard correctly, the question was, I have a pre-existing mental illness. Can I go ahead and get pregnant? So the key thing I want us to take from this is that if you have a pre-existing mental health condition, unlike the average Ghanaian woman, you have to plan your pregnancies. Usually we don't plan our pregnancies, but if you have a pre-existing condition, plan your pregnancy. And Dr. Kumi said preconception care, which is very important. So if you're going to plan your pregnancy, it means that you're going to get in touch with your obstetrician and your psychiatrist even before you get pregnant, so that all the questions that you have, all the anxieties, implication of even transferring your child having your mental condition, the risk to your child, to the pregnancy journey and all that can be answered. You can be monitored properly and the journey can begin. So the key word is plan your pregnancies. Thank you.
Thank you. Thank you. Thank you for adding that. Okay, so whilst Madam Vivian still works on her slides, there's another question here, maybe for the two of you again. So she says that in my walk through pregnancy, no one asked me a question about my mental health. It was all injections and tablets. How are we going to get access to our mothers who really need attention? I find the care as disjointed and not helpful. Doctors have to call each other. If there's no call, you are in trouble. If there's no call, you are in trouble. How do we go about answering this question? Dr. Alberta, Dr. Kumi, anyone can help out.
Yeah, so thank you very much. I think that this is a very unfortunate situation, but as has been asked, this is actually common. This is not unique to this patient, and it calls for all of us practitioners, and to this particular question, to all care providers, midwives, medical officers, as in family physicians and obstetrician gynecologists who attend to patients. We have a very useful tool, not all that perfect, our maternal and child health record book, which we commonly call the antenatal booklet. A lot of work is going on behind the scenes from Dr. Sefoga's work, with help from the WHO team and other partners, to help incorporate maternal mental health into routine practice. But currently, what we have in the maternal and child health record, that's the antenatal book, actually antenatally ask about personal history of mental health disorders. They talk about family history. But I think, as one of the presenters talked about, we may take these things, but that is where it ends. We don't go further. In fact, I've had situations where a patient has come to the consulting room and that aspect has been taken, no. Personal history, family history, no. But she said nobody even asked her a question. Then at the postnatal aspect, there is a part in the maternal and child health records that actually demands that we ask the patient about mood changes. We have to ask ourselves whether we are asking these questions. But like I'm saying, or like I said previously, a lot of providers do not know the care pathway available. So, okay, if I go and ask this question, what is the next step? So we don't have a perfect system. We have a book, the MCH handbook, that, tries to tease out a few things, but even that we are not utilizing well. So the experience from the person is really true, and it's happening to a lot of patients. I think Dr. Jifar talked about it. We need to start the conversation because of the kind of, society we have where there is that relationship between the provider and the patient or the mothers is more like one of, a power, somebody with power and somebody with less power. Our women culturally will not start the conversation. The book is giving us some pointers to start, but we still are not. So this is a call for all of us to look at the MCH handbook, use it, albeit with, the challenges that it has, but let's start the conversation. Let's help our women have these conversations. Sometimes for the patient, just the fact that you've even asked about this is something that, helps her build resilience. So that's my response to that. Thank you very much. Yeah, Dr. Sefa.
Yes, thank you, Dr. Kubi. Dr. Siasama, would you add something to it? I think it's similar to the comment you made when you were presenting. The lady is saying that it's all about injections and tablets. No one asked her anything about mental health.
Yeah. Yeah, and that is very important because, and we have to look at, as I said, we have to look at our practice because we oftentimes focus on the very obvious issues where, we talked about postpartum psychosis, the depression, but some of these things may start in a very subtle manner. And that is where we need to start having the conversation. We need not wait. All the risk factors we talked about shows that this is very common. In Korle Bu, the work that was done by Dr. Sefuga and team is as high as 41%. You talk about poverty, you talk about women who have had bad experiences in labor, women who are not respected. A lot of our patients fit this, these risk factors. And they are asking us to start the conversation, to help them break the stigma. All right. So I think these are, the things that we have to look at. The person may not come obviously with the psychosis, but we need to start the conversation because the fact that the patient is calm, the fact that she is not, making a scene doesn't mean that all is well. So let's start the conversation. Thank you.
Thank you. Thank you, Dr. Kumi. Dr. Jifa, if you are there, I think this one you would help us out. Yes, so she's saying culture. Yes, Dr. Jifa.
Yes, I'm here.
Okay. Sorry, let me mute. Okay. So there's a question here where the participant is saying that culture defines us and culture determines how we behave and cope with life. And so our culture affects us, he thinks, our resilience and our coping strategies. How does culture impact on our resilience and coping strategies? And what can we do when we are faced with our cultural practices? How do we maintain our resilience?
Well, I think, like I emphasize, that even for developing our sense of resilience, if you look at the broader factors, culture plays a huge role. And sometimes our impressions of what culture is. So culture is our way of life. And it is evolving. So there are certain things that we didn't do in the past that we are doing now. And I think it also reflects in the way we respond to some of these issues. In the past, and mothers that I have spoken to would tell you, even though my mother may be supportive, sometimes the sort of thing she tells me, it puts a lot of fear. And I think in the past, there was a way of communicating information, which for many hasn't been helpful. Therefore, such culture should evolve. So one of the things that we have come to find out is the simple technique of explaining a procedure or providing accurate information to a mother that during this period, it's likely you may experience A, B, C, right? If you experience this, it is normal. Or if you experience this, please bring this to our attention. Those are the kind of things that you would expect. One of the things that we have a problem is speaking up. And you would even find that from Dr. Sepoga's research on the situational analysis, some others could not speak up, but others were a bit more vocal. Expressing our feelings is one difficulty that we have, and it's a cultural thing, but you realize that over time, we are speaking up on some of these issues. So although in the past, we may not have had the opportunity to speak about some of these things, we need to also evolve. We do have cases where, because of the individual's condition, and maybe the person is struggling with a severe mental health condition. So instead of them sending the individual to the hospital, they've been sent to a prayer camp. One of the things that we need to continually do is to educate every opportunity. So not only to professionals, because who is taking them to the prayer camps? It's the family members. So beyond just working with ourselves, we need to go and educate the community. So looking for various opportunities and platforms to talk about some of those things so that we do not use culture as an excuse not to provide quality and adequate care. I hope that was helpful.
That works out well. I think you've fully answered the question for the participant. Thank you very much. Dr. Alberta, are you here?
I'm here.
Okay. The question is, the participant is saying that she has to take medication for her condition, most likely a pre-existing mental health condition. Is she not responsible in exposing her baby to developing mental illness?
From the medication, is that the participant's worry? That's the medication.
Yes, the medication. Her worry is that the medications that she is taking for her mental health condition would affect her baby. And actually, let her baby develop a mental illness?
So the simple answer is no. You taking the medication will not, the medication is not going to, what I want to say is that medication does not predispose, it's not a risk factor for developing mental illness. So that is the simple answer. That's no, that cannot happen. There are other things that may occur, but that's perhaps, I mean, we can talk about side effects of the medication. We are talking about in utero exposure to medication. We can talk about postpartum exposure through breast milk and things like that. But the specific concern that it will cause mental illness in the baby, the medication, it's not true. So the participants shouldn't be worried about that. If they have other questions, they can hit me up privately so that we can delve into it more. I hope I've answered the participants.
Yes, Dr. Alberta, you have. I think this is the final one. The question keeps on coming up. So the question is, I think it cuts across for all three presenters. What about women who opt to terminate pregnancy? Okay, what help is out there for them? Dr. Kumi, if, for instance, somebody wants to terminate pregnancy, is the system well placed to help the person out? And psychologically, Dr. Jifa, what help is there for them currently in our facilities? Alberta, you can also chip in. What help is there for somebody who opts to terminate pregnancy?
Yeah, so Dr. Zifa, thank you. This is a very important question because all through the presentations, when we talked about the risk factors, you know, unplanned pregnancy, unwanted pregnancy, difficult relationships are all risk factors. I think for practitioners and healthcare providers, the first thing we must appreciate is that for a woman to make that choice of terminating a pregnancy, it's a difficult decision. Again, for a woman to continue the pregnancy is also a difficult one. Let's remember, we are not treating ourselves. We are treating the patient and their concerns. So, yes, our, religious backgrounds and cultural backgrounds, make us feel like this should not be mentioned, that I am pregnant and I want to terminate it. I think all through the presentation, we also talked about it, that for some people, the comment they'll get is, this is something people have been fighting for, so people have been praying for. Now you get pregnant, you want to terminate it? So we make them even feel bad. So then they don't want to even approach a facility. But evidence-based practice doesn't recommend that. We tell patient, this is a bad decision or this is a good decision. We need to listen to the patient. That is the key thing. We need to listen to the patient. The aim is not to talk them out or talk them in. Let's understand where the patient is coming from. If you are unable to offer the service to the patient, we have pathways of referring the patient to other people. Let's remember, even when you take our abortion law as a country, yes, it is a bit restrictive, but there's a lot of room, because it is said in the law that if continuing this pregnancy affects the mental health status of the patient, it is allowed. But I think the point is that the decision for any woman to terminate or to continue a pregnancy is a very difficult one, and we must appreciate that. Let's have a broad discussions with our patients, and if we are unable to offer them the service, which has to be safe, we have to refer them to the right people who can offer them the safe termination service. Thank you. So I think Dr. Jifa can also add theirs to it. Thank you.
Okay. I wanted to say that abortion guilt is a real thing. I've had, at least off the top of my head, about 2 patients who years after the termination had a lot of guilt and actually came to us because eventually they became depressed. I also had the privilege to speak to somebody who had an abortion outside the country. This is okay. Well, I'm using medical terms abortion. So let me use what you use. And there in the clinics, there's a counselor there who counsels you before the procedure. And if you need post-care counseling, post-procedure counseling as well, it is done. Unfortunately, as Dr. Kumi alluded, here in Ghana, it's not structured like that. I don't know if abortion is still, I have to update my knowledge on the law, if it's still illegal. So it means that these are things that are done clandestinely, unless it's a medical abortion, you've been advised to do it. Other than that, if it's your own choice and not for medical reasons, then it's clandestine. So I have to visit Marie Stopes and see if they have a counselor there. But to the best of my knowledge, there's nothing like that. So you, the person who has taken that decision, yes, our doors are always open. You can visit any of the psychiatric hospitals or government hospitals where there's a psychologist or a psychiatrist and speak to one before you go through the process, and after the process to speak to one. So that option is there. It is not married into the abortion care plan. It's a separate thing, but you can always access it. Thank you.
Thank you. Thank you, both of you. I can see a hand up, Godfred Amedro, and then a comment by one family physician. But we have Madam Vivian back on. Madam Vivian, can you hear us? Hello.
Hello.
Can you hear us?
Yes, I can hear you.
Okay. Can you kindly do this in 10 minutes?
Yes.
Yes, please. So please do this in 10 minutes so that we can conclude.
All right.
Thank you.
You're welcome. Please, can you see my screen?
Yes, please. You can start. I can see your screen.
Okay.
Madam Vivian, so you can start. We can see your screen. So you can click on the button on your far right for the PowerPoint presentation. Or you can just start with what you have. We can see clearly.
Thank you. The presentation outline. I'm starting with identifying at-risk mothers during booking or ANC, and then identifying at-risk mothers at labor or delivery, and then identifying at-risk mothers at postnatal, supporting such mothers with the aim I can't see him coming. Okay. With the aim of minimizing the risk of maternal mental health, and also to support for the midwife. Introduction. In fact, midwives play a crucial role in identifying mothers at risk throughout the maternal healthcare journey. By employing a comprehensive approach, midwives can effectively assess and identify at-risk cases at various stages. How can we identify at-risk mothers during antenatal or booking? We are to conduct thorough medical and obstetric history, assess socioeconomic and cultural factors, such as educational background, history of traumatic experiences, and also identify pre-existing medical conditions such as diabetes and hypertension that the woman had before getting pregnant. To also take history on previous obstetric complications such as postpartum hemorrhage, preeclampsia, and all those conditions that she might have had during the previous pregnancies and deliveries. We should also assess or screen for mental health concerns. How do we do that? We ask open-ended questions, which will allow the woman to talk openly. And whilst doing that, we all know that if we allow the woman, by giving her a psychological environment, show concern, listen attentively to her, try and do things that will maintain her dignity, she will be able to give us accurate history. We are also to assess BMI and nutritional status, and also inquire about substance abuse or smoking. Our new MCH record book, I think at the second page, has history taken, and it has majority of all that I'm talking about. If we are able to dialogue with them well, we'll be able to identify mood and emotional status of the woman. If she has sleeping disturbances or appetite changes or vague energy levels or concentration difficulties, all this will tell us that no, this woman has a challenge or mental health challenge. Now, let's look at identifying at-risk mothers at labor and delivery. A history of previous mental health will tell us a lot. An example is previous diagnosis, hospitalization, or treatments for medical health concern. A current mental health symptoms like current symptoms such as anxiety, depression, or suicidal thoughts will give us a clue that no, we have to shine our eyes better at this woman and counsel her or put in measures to refer her to the appropriate service giver like the psychiatry hospitals. We also have our clinical psychologists in the various hospitals. For stigma's sake, if there's a clinical psychologist around or very close, we can refer the woman to the clinical psychologist. Then traumatic birth experiences. I remember in Kolebu, a woman who had a previous traumatic birth experience came the second time, and you could see that she was shivering. You ask her questions and she was crying just because the memory of the traumatic effect was so fresh, and she was afraid that she may get this type of condition again. Social support. In our assessment, we have to ask the mothers if they have good social support network, including the partner, family, and friends. For you know, that day when she was coming to the hospital, because she's not in good terms with the husband. She couldn't even tell him that he's going. And so no transportation was given to her, especially women who are not working. Coping mechanisms. We have to evaluate the mother's coping mechanism, such as substance use or avoidance. Life stresses. We need to identify recent stresses like relationship issues, financial problems, or housing instability. Cultural and linguistic barriers. We need to consider language and cultural barriers that may impact on mental health of the woman. Lack of prenatal care. Most often, the women come in with the antenatal cards. And when you notice that after registration, this woman does not come for ANC again, then you, the midwife, should start thinking through what might have been the cause. Is it that she wasn't having money to come? Or that she's mentally disturbed or have social issues? That is why she's not coming. Then you probe better. And as you probe, you'll be able to identify issues that led to her inability to continue with the prenatal care. Some also are not having their own husbands. And so they wouldn't want other people to even see them at the antenatal for them to know that they are pregnant, for fear that people may start asking about their husbands. Most often, we, the midwives, also at the clinic, as part of our biodata collection, we ask about, Mommy, can you give me the name of your husband? Things like this should be done with dignity so that those who are not married will not be disturbed or will not be found wanting. And whilst taking this history, we have to ensure that there's a lot of privacy. Is there somebody hearing? Is there somebody seeing? Then unplanned or unwanted pregnancy, we need to identify mothers with unplanned or unwanted pregnancies, which may increase mental health risk, especially our younger ones. For you know, she was in a trade, she was in an education, and this happened. So already she's not in a good psychological state. So once we are able to identify things like this, we put measures in place to guide them with all the measures that my earlier presenters have mentioned. Then domestic violence or abuse. We need to screen for domestic violence or abuse, a significant risk factor for mental issues. Substance use. We are lucky in Ghana, the rate is not so high, but it's ongoing. We should assess for substance use or addiction, which can exacerbate mental health concerns. We should also ask previous childhood trauma. We need to inquire about childhood trauma or adverse childhood experiences that she might have gone through. By recognizing these indicators, healthcare providers can initiate early interventions, refer, and also support, ensuring comprehensive care for at-risk mothers during labor and delivery. Now, how do we identify at-risk mothers at postnatal? 1, identifying maternal mental health at-risk mothers during postnatal period is crucial for timely interventions and support. Some potential indicators to help identify at-risk mothers are anxiety and stress. We need to ask about anxiety, stress, and feelings of overwhelm. At times when we are taking history from these women, you talk to them and they are not responding. We need to be patient and loving. We don't have to shout, Mommy, are you not the one I'm talking to? Be calm, because you don't know what she's going through. Kindly probe further and handle her in a very reassuring manner that will encourage her to tell you whatever she's going through, so that you can do some psycho-education or psychotherapy or even refer to a clinical psychologist. Some also complain about sleep disturbances. Yes, we take history about sleeping pattern. We shouldn't ignore it. It's very important. We need to inquire about difficulty sleeping or excessive sleepiness. Then a lack of emotional support. We need to assess the mother's perceived lack of emotional support from partner, family, and friends. In Ghana, we are lucky again that irrespective of how good your marriage is, your family are around. And anytime you need them, you can pick one of them as a significant other to go along to the health facilities with you, or even invite a friend to give you that social and psychological tap or guide. Difficulty bonding with baby. At postnatal clinic, I remember somebody told me, Ma Vivian, me ba we dear, me di na wo. Trying to dash me her baby. And I asked, sweetheart, why? This beautiful baby that you have delivered, don't give it to me. The baby is yours. Sweetheart, sit down. And then whilst I keep on probing and talking and playing around with her, she told me a lot as a sign that she was having postnatal blues. By the end of our dialogue, I noticed that she was crying. And at the end of the day, she said, Mommy, I can't imagine myself going home with this baby. How am I going to handle her? Hey, can I be a responsible mommy at home? You see, if a good postnatal counseling is put in place, the women will be able to know all these things, and then they won't enter into it, or the rate at which we get cases like that will be minimized. Then physical symptoms such as persistent such as headache, chest pain, or gastrointestinal issues has to be looked at. Substance use or addiction. We need to assess for substance use or addiction which can worsen mental health concerns. Some already have history of mental health. So if they take these substances or they are exposed to issues that will irritate them, they exhibit signs. Then social isolation. We need to identify mothers with limited social support or feeling isolated. I remember when I was practicing public health, anytime we identify women with lack of social support, we refer them to social welfare. And at that time, social welfare do take up, and I don't know what the situation is now. Now, let's look at supporting such mothers with an aim of minimizing the risk of maternal mental health. In fact, early identification and screening helps a lot. We should regularly screen mothers for mental health concerns, emotional support and validation. We should offer empathetic listening, reassurance, and validation of their feelings. We should always refer timely mental health professionals such as therapists or psychiatrists. We shouldn't behave like we know it all as midwives. We all have our specialty areas, and I will plead with all of us that we make sure that we always include other health personnel in our midwifery practice. We have the clinical psychologists, the psychiatrists, community psychiatry officers. We should include them. We should also ensure that they have participation in peer support groups, such as postnatal counseling. We are already having pregnancy school, but after delivery, we also give them some counseling. But if we can also come out with support groups, like we gather all the women who have been discharged and they are about going home, then we give them postnatal counseling. The next one is to provide access to counseling and therapy sessions. We should also help mothers build and leverage social support networks, including family, friends, and community resources. The almighty partner and family support is here. We need to engage partners and family members in the support and education to enhance understanding and empathy. If our couple are able to come along with their clients to the health facility during antenatal or labor or postnatal, whatever health education or counseling that is given can be discussed by the husband or the two of them, the husband and the wife, so that the husband will be in a known of exactly what was discussed. By so doing, he will be in a better position to give the needed support to the woman. Then breastfeeding support, especially for new mothers. It can be very stressful and even cause anxiety. So if we can emphasize or do more on our breastfeeding support, when they are discharged, we can also refer them to the community health nurses within their locality, especially the new mothers, so that the community health nurses during their home visit can visit mothers like that and continue with the support that has been started within the health facilities. We need to give them follow-up appointments. We need to schedule regular follow-ups appointments to monitor mental health. We should continue with collaboration with healthcare providers, ensuring open communication and collaboration with healthcare providers to address mental health concerns, especially in our referrals. Don't just say, Mami Kwadabraka. When you go to Adebraka, on your left side, the hospital there, go. No. If we are not too busy, a nurse can be assigned to go along with her, or call the receiving end that such a client is coming, so that we don't just throw the client into the air. When they know where they are going and the recipients or the receiving side has been informed, the care is always warm. Then cultural sensitivity and awareness. We need to provide care that is sensitive to the mother's cultural beliefs, values, and practices. How can we do that? If accurate history is taken, especially on cultural sensitivity, we'll be able to know the cultural background and the beliefs of the woman, so that that individualized care, including counseling, can be given to her. I believe by implementing these strategies, healthcare providers can support mothers at risk of maternal mental health issues, minimizing the risk of complications and promoting a healthier postnatal experience.
Thank you, Madam
Now,
Vivian.
yes.
Yes, you have just about 5 minutes to wrap up, so kindly wrap up for us.
Thank you.
Thank you.
Now, support for the midwife. We need to train and educate the midwives. They are already trained and educated, but those who have already completed and they are working, we need to review guidelines and protocols that will be clear enough for them to be well updated to render their service. If we can also have mentorship and support for them, like pairing a junior and a senior nurse together, so that the senior can mentor the junior one, meaning that that senior one should also be given some updates on maternal mental health, so that by so doing, accurate and appropriate mentorship can take place. We should make available resources and equipment that the woman, the midwife, can use for her care. If we are talking about privacy, maintenance of dignity, and as facilities are not well structured to provide such a service, it can be frustrating. Then continuing professional development. The fact that they are completed or they've completed their school is not to say that that is all. we should learn to continue learning. If there are workshops like this and they are invited, they should come on board and update themselves so that they can take informed decision in what they are doing better. The recognition and incentives. In fact, midwives are going through burnout sessions. Most workers or health midwives have relocated, and a few are doing the work. So they are burnouts. So if the few ones that are working are given that recognition, or even incentives are given to them, they will be better enthused to render their service. That interprofessional collaboration, like the midwife in the labor ward collaborating with the psychiatry unit of the hospital, the community psychiatry officer, and discussing the care of clients with them, so that professional collaboration will be there for effective care. Then quality improvement initiatives, like at the end of the month, analyzing the work that we have done, identify the gaps, and put in measures that we can use to rectify or fill in those gaps. Then addressing workload and burnout. I believe strongly that if our protocols and guidelines, we are able to review them to include a lot of psychiatry or maternal mental health issues, these midwives will be well updated and be able to take care of these women by identifying their mental health issues, and then appropriate attention will be given or referral. Thank you so much for listening.
Thank you, Madam Vivian. It shows clearly that midwives are very key in providing quality maternal mental health. Thank you so much. I mentioned that there's a comment in here in our chat box that has to be read. It's very important. From one of the participants. Great. Kindly allow me to share. Great presentation so far. Thank you to all presenters. I have a contribution, however. Family physicians cannot be left out. Family physicians cannot be left out of the relevant health team in the context of this presentation. They were not included in the slides. Their role cannot be overemphasized. This is the patient's primary care specialist who is with her during the preconception, conception, and postpartum period, as well as with her family, who play a major role in her recovery. They also coordinate the patient's care if there is a need for psychiatric or psychological evaluation. Thank you very much for this contribution. The CPD committee has taken notice of this and will make the rectification if we have to for other presentations. Thank you very much. There was a hand up before Madam Vivian came up to present. Godfred, are you still on or he's left? Okay. I guess he's dropped the line and now. So in summary, building resilience basically means that we are uncovering the strengths and protective factors of our mothers, both the internal and external attributes. Tell moms to focus on the positives. Tell your clients to focus on the positives. And mothers can be affected with a wide range of mental health conditions. The most common ones we come across are postpartum blues, postpartum anxiety, postpartum depression, and the severe form postpartum psychosis. We cannot end by mentioning that communication is very important when it comes to quality maternal mental health. This phrase came up when Dr. Kumi was presenting, respectful maternal care. Every word from us as healthcare providers, every word from us is important to the woman. Let's listen to our mothers. The pregnancy journey can be less stressful if, as healthcare providers, we understand the needs of our mothers at various stages. This cannot be overemphasized. Our communication with our mothers is key to providing quality maternal mental health. It's Purple Month. It's maternal mental health awareness, creating awareness in the month of May. And we want all of us to go out and color the month purple by taking the knowledge and skills we've gained today to our consulting rooms, to our health talks in schools, and when we are engaging media. Let's practice what we have learned today so that we keep it at our fingertips. We have collectively come together and we know that there's a lot of work to be done when it comes to maternal mental health. And we believe that we can achieve it if we all play our role. Thank you very much for joining this webinar. We said that CPD, we said that it is MDC accredited. We hope that you provided your full name as registered with your professional body and your MDC PIN. Join us tomorrow at our public lecture, our second public lecture at the Ghana College of Physicians and Surgeons as we continue to color the month of May. Thank you very much. I am Dr. Susan Sefa, and I've been your moderator and host for the CPD. Thank you.
Thank you. Thank you very much.